morning, good afternoon, and welcome to our Human Resources for Health Spotlight series. And today the topic is Global COVID-19 Health Workforce Responses, Recruit, Retain, Reskill, and Support the Health Workers. And we will zoom in a little bit more on the mental health protection today. I said it's a series. Yes, it's the first installment in a series of 3 webinars. They are all based on our joint work with the colleagues in WHO headquarters for the Global Forum on Human Resources for Health, which took place like 3 weeks ago. And I'm very happy actually to say that we have today excellent speakers with us. And one of the speakers is our spotlight speaker, our keynote speaker, Margaret Ziemann from the George Washington University in the US. Margaret is the co-author of one of the policy briefs the webinar today is based on, and we are very happy to have her, that she is summarizing the key issues and messages coming from this policy brief. I'm also very happy to announce that we have as a spotlight speaker here from Finland, Eva Tuanainen from the Finnish Emergency Medicine. And Eva can tell us firsthand actually about mental health issues in Finland and how to address them. And they have quite good insights into it because they are researching and evaluating these interventions. And I'm also very happy to announce that we have with us today Aisha Holloway from the University of Edinburgh. Aisha is a renowned nursing researcher. And again, we are very interested to hear about Scotland and the UK in particular when it comes to the mental health protection of health workers. And last but not least, Jim Campbell is with us. Jim Campbell is the director for Human Resources for Health with the World Health Organization in Geneva. And he's behind the Global Forum on Human Resources for Health, which took place just 3 weeks ago, focusing on one hand on working conditions, secondly on how we work with education, finance, and employment, and thirdly, where do we get actually all the money from it? And this is also the sequence of the webinar series we will have over the next 2 weeks. And last but not least, I would also mention my colleague Erica Richardson, who is looking after the chat box and is also introducing in a minute the poll, the audience poll. But before we start with that, just a couple of words on the housekeeping. First of all, please use the chat box for all your comments, questions. If you have a document you would like to share, put it in the chat box, let us know. And Erica will feed back all the questions and comments you made through to the panel discussion at the end of this meeting. Also, this session will be recorded and you will find it very soon on our YouTube channel. So, okay, I think that's enough for the introduction. And now I would like to ask Erica to present the participants poll. Erica, what are today's questions?
Hello there. Thank you very much. Annalisa, if you could launch the poll. We just wanted to check in with you and get a little bit of background. So the first question is supporting health and care workers a policy priority in your country? That's a straightforward yes or no question. And then secondly, have any of the following policies and practices introduced in response to the COVID-19 pandemic been expanded? And for this, you've got multiple options. So maybe it's changing scopes of practice and introducing team-based roles, greater use of technology and digital tools, more flexibility, regulatory frameworks for practice, protecting the physical and mental well-being of health and care workers, or indeed none of the above. So very interested to get your insights on that. Thank you very much. Back to you in the studio, Matthias.
Thanks, Erica, for all these questions. I think they are very useful because they are helping us to scope a little bit what's the topic today of the webinar and also what's in the policy brief. Now, that's great. And now is the moment where I would like to invite Margaret Ziemann to take the floor and give us a little bit of an overview on the policy brief you have co-developed, for the 5th Global Forum on Human Resources for Health. Please, the floor is all yours.
Good afternoon, good morning to everyone on the call. It is a pleasure and an honor to be here to discuss this important topic and to share some findings from the first in this series of policy briefs, as Matthias mentioned. COVID-19 brought to light many persisting workforce challenges, underscoring the plight of health and care workers and the importance of long-sighted policies to build a robust workforce capacity. Yet it also spurred rapid innovation in terms of workforce planning and policy, showing that change to and improvement upon the status quo is in fact possible. Though no doubt born out of necessity in response to a global crisis, important lessons emerged from this period that we can carry forward. So the aim of this policy brief was thus to review emergency workforce strategies implemented globally during the pandemic, the evidence for their effectiveness, and the implementation considerations for their long-term sustainability. Over the next few minutes, I'd like to walk you through some of these innovative strategies. And while I don't have time to review the evidence for each as is contained in the brief, what I'd like to do is highlight a few findings which I think have important policy implications for moving forward if we are to build and sustain an adequate, agile, and well-supported health and care workforce. Before doing so, I do want to quickly thank my co-authors on this policy brief, both at the Mullen Institute at George Washington University and at the European Observatory on Health Systems and Policies for their tremendous contributions, and their names are on the image in front of you. Health workforce challenges posing ongoing threats to health systems worldwide predated the pandemic. Worker shortages estimated at 10 million workers prior to COVID-19, geographic and specialty maldistribution, and skill mix imbalances are among the critical health workforce issues facing countries across the globe, and they were there prior to the COVID-19 outbreak. So starting point capacities of countries' human resources for health to respond to a large-scale public health emergency were not great. COVID-19 then put incredible strain on health systems and the health and care workforce, rapidly increasing demand for healthcare services. Simultaneously, health workers were dealing with the consequences of the pandemic themselves. Fear, competing demands, including family caregiving, quarantine, infection, and tragically, death, exacerbating pre-existing shortages and workforce vulnerabilities, thus further limiting health systems' capacities for pandemic response. In response, countries around the globe employed strategies to quickly bolster the capacity of their health and care workforce. These strategies predominantly fall into three categories. The first, surging the supply of the health workers. Second, optimizing their use in terms of setting skills and roles. And thirdly, implementing measures to support and protect health and care workers. And I should note that many countries took a multifaceted approach to address the health workforce needs by employing strategies across each of these three categories. In terms of increasing the supply of health and care workers, countries took two broad approaches: maximizing the availability and distribution of their existing healthcare workers, and by recruiting new emergency healthcare workers. To maximize existing workforce, worker schedules were often modified, for example, by canceling leave time, mandating overtime, or shortening quarantine and isolation times for workers that had been exposed to the virus. Countries also redeployed their existing workers across geographical regions, taking steps to facilitate the movement of workers from low to high demand regions. But increasing the workload of the existing health and care workforce often was not enough. And so countries had to bring in additional healthcare workers. Specific strategies included recruiting health professions students, bringing back retired or otherwise inactive healthcare workers, hiring foreign trained workers, and using workers from the private sector and other government sectors to aid in the response. Now, these strategies have been used in response to prior disasters, and evidence indicates that they are, in fact, effective at increasing short-term worker supply, capacity, and mobility. Yet, unintended consequences must be considered. In terms of maximizing the existing workforce, the evidence indicates that modifications to workers' leave and work schedules, like those measures implemented during the pandemic, harm workers' mental and physical health, increase turnover and tension, and can jeopardize patient safety. The targeted recruitment of emergency health workers, meanwhile, can jeopardize the health of volunteers, particularly retirees, add supervisory burdens to the existing workforce, and in the case of foreign trained workers, come with ethical considerations around the treatment of these workers and the negative effects of their out-migration on home countries, many of which already have fragile healthcare systems. Countries' health systems also had to flex to optimize their existing workforce and the resources needed to meet changing demands. One strategy was to redeploy health workers from healthcare settings where non-essential services had been limited, such as the case of dental teams being redeployed for COVID testing. Workers, such as community health workers, were also trained to perform new tasks like contact tracing. Patients and caregivers were empowered to take on greater roles in their own care, such as self-administration of treatments, to reduce the burden on healthcare workers. And the use of digital technology proliferated. Telehealth, in particular, surged in many countries to maintain delivery of health services, protect patients and providers from virus exposure, and mitigate inequitable access to the health workforce. For example, tele-ICU programs allowed community-based and rural hospitals to connect with multi-specialty ICU teams. Early evidence finds that telehealth uptake due to COVID increased access to mental health services. Tele-ICU models like those implemented have been shown to expand ICU capacity and support evidence-based care while decreasing patient mortality. However, the potential benefits of digital technology and telehealth are dependent on access to it, and disparities were apparent during COVID-19 based on geography and patient factors including education, race and ethnicity, and socioeconomic status. Before moving on to strategies employed to support and protect the health workforce, I want to provide context for the need to do so. Even before the pandemic, health workers faced enormous occupational risks to their physical and mental health, resulting in high rates of injury and illness, anxiety, depression, post-traumatic stress syndrome, and burnout. COVID-19 exacerbated and added to these risks for health workers across the globe, with factors related to the coronavirus, the work environment, social stressors, and additional support needs eroding worker well-being. These risks translated to increases in all the outcomes that I just mentioned, tragically including an estimated 115,000 worker deaths by the spring of 2021 alone. After initially facing challenges, many countries implemented measures to protect and support their health workers' physical and mental health. In terms of physical safety, countries implemented strategies to mitigate COVID-19 infection risk among workers, including the procurement and adequate distribution of PPE, infection control and prevention training, universal screenings, and physical distancing protocols. The emergence of COVID-19 vaccines represented a turning point in the pandemic, and many countries prioritized their workers and vaccination strategies. There is unequivocal evidence that vaccines are effective at preventing infection and severe disease among healthcare workers. However, stark disparities in access to and uptake of COVID-19 demand greater attention paid to the prioritization of vaccine equity and trust building. The evidence finds that vaccine hesitancy among health workers is higher in females, those of younger age, and those from low-income countries compared to their counterparts. The strategies implemented within and across countries to support the mental health and well-being of healthcare workers during COVID-19 primarily focused on individual level mental health services like remote counseling, helplines, and mindfulness. While there is evidence that individual mental health strategies may attenuate some of the effects of workplace stressors, they fail to address the organizational and systems level drivers that cause them, things like excessive workload, inadequate staffing, administrative burdens, and lack of job control, and thus do not address known drivers of burnout and mental distress among healthcare workers. Countries also put in place a number of practical measures to support health workers, including transportation, safe accommodations, additional pay, and childcare. Childcare is a significant source of stress for health workers, especially women, who make up 2/3 of the global health and care workforce and are also disproportionately responsible for childcare. Childcare stress among health workers is associated with increased odds of workers experiencing anxiety, depression, and burnout, which in turn can adversely affect worker retention and patient safety. Therefore, it's reasonable to assume that programs to address childcare challenges, like those implemented, could alleviate worker stress and its consequences. The strategies discussed on the prior slides would not have been possible without the support of governance, financial, quality, and technical policy and infrastructure mechanisms needed to implement them. In terms of governance, strategies necessitated policies, legislation, and regulation at the national and regional levels. These emergency measures also required funding, and countries allocated significant finances towards initiatives to establish registration systems, telehealth infrastructure, hiring, salary increases, and worker trainings. Quality measures, such as the rapid development and dissemination of training and guidelines to support the delivery of high quality care, especially in the face of a novel pathogen, were also necessitated. And lastly, countries' technical capacities had to be bolstered to meet COVID-19 demands. This included systems for workforce data and tracking, identifying and sharing evolving best practices, testing and epidemiological monitoring, PPE procurement, and vaccine supply and administration. Countries can capitalize on the lessons learned and progress achieved during COVID-19. So what have we learned from this global natural experiment that could be taken forward to inform future health workforce policy? For the sake of time, let me just elaborate on 4 of the points below. For one, emergency measures to rapidly scale up the health workforce were intended to address acute demands, but if carried forward, could do more harm than good. For example, ongoing cancellations of worker leave or requirements for increased working hours would further erode job quality and harm worker well-being, exacerbating issues like burnout. Moving down to technology, the pandemic provided a strong proof of concept for the expanded use of digital health tools, including telehealth, which hold enormous potential to improve delivery of healthcare and patient outcomes while reducing workloads and supporting and protecting the workforce. However, strategies must be implemented to address inequitable access to digital health tools within and across communities and geographic regions, and digital health competencies will need to be developed to support workers in optimal utilization. Next, the urgent need to tackle retention issues in response to high rates of attrition, outward migration, and strikes demands long-term commitment to improving working conditions and job quality. Many of the strategies employed during COVID-19 serve as strong examples that, if carried forward, could represent long-term health workforce retention solutions. These include adequate wages and benefits, strengthened biosafety protocols, on-demand access to PPE, free, confidential mental health supports, enhanced education and trainings, and family supportive services like childcare. In summary, worker well-being must be that which guides efforts to improve workforce retention. And these are the kinds of measures that will necessitate change at the organizational and the systems level. Next, one-size-fits-all health workforce policies, which were the norm during COVID, may not be appropriate for addressing the needs of a diverse workforce. The pandemic shone a light on the outsized role women play on the front lines of healthcare in the home front, yet they're underrepresented in leadership positions. Long-term care workers were at disproportionate risk for COVID-19 infection and death, yet they're paid some of the lowest wages in healthcare. And Black healthcare workers in the United States were more likely to report vaccine hesitancy than their white counterparts. These findings demonstrate a need for targeted approaches to strengthening the health workforce, elevation of the worker voice in policy and decision-making, and a commitment to efforts aimed at building trust with healthcare workers. So I leave you with this culminating message. A fundamental lesson of the COVID-19 pandemic is that addressing the health workforce as a comprehensive and ongoing area of policy and planning cannot be ignored. Moving forward, a well-supported workforce is necessary not only in times of global crisis, but also to advance pre-existing aims, such as the Sustainable Development Goals and universal health coverage. Health and care workers must be supported and protected as a means to strengthening health systems worldwide and as an end unto itself, both now and in the future. Thank you.
Margaret, thank you so much for this amazing overview and also for being very concise and mindful of our time budget. And I think it was really great to see that you zoom into the 3 strategies: increase the numbers, optimize utilization, support and protect. And of course, you know, some of the measures taken during COVID-19, you know, they are unsustainable, but others, I mean, you were referring several times to increase the supply. I think this is one of the sure lessons coming from COVID-19, that we need to increase the supply worldwide. Flexibility, learning opportunities, new roles and new models are very much at the forefront of improving the health workforce. The use of digital tools, you know, either for coordination or for communication with the patients are key. And you were also talking about the fair and safe working conditions and additional payment. And today, of course, you gave us the overview on all COVID-19 lessons for the health workforce. But today we will focus and zoom in a little bit more on the mental health protection. And I'm very keen to hear about our spotlight speakers. So Margaret, thank you so much. But before we go to the spotlight speakers, Erica, I think it's time to release the poll results. Can we see the poll results, Erica?
Yes, Annalisa, would you like to put them up on the screen? So
here we are.
Here we are. Very, very interesting. I'm actually struck by the fact that nearly half of the respondents say that supporting health and care workers is not actually a policy priority in their country, even after the most acute phase of the COVID pandemic that we've been through. By far the most common policy practice introduced in response to COVID-19 that's been expanded is the use of digital tools and technology. So that's something also very interesting to see from our audience. So yeah, thank you very much for that, everyone. Really, really.
I think I must say I find this almost a little bit shocking, because Margaret was just providing us with this great overview on the COVID-19 learnings, and the lessons are on the table actually. And then we see here that half of the audience said, I'm not quite sure about my country. I think this is not really much of the priority of the government. And then changing the scope of practice has only very low support. So that's quite worrying. So we cannot take it for granted actually that the COVID-19 lessons for the health workforce are picked up. I think we still need to provide a lot of political support and pressure here on these topics, but still at the same time, I think that there's also some political momentum. Now that's the moment where we are planning to zoom in a little bit into the topics of the support for the health workforce, and in particular on mental health. And I'm more than happy to give Eva the floor. Eva is actually not only working in emergency medicine, you're also the founder and president of FinEM, a non-profit organization of nurses and doctors working in emergency care. And of course, emergency care in COVID-19, that was, prominent as nothing else. So Eva, please provide us a little bit of your insights. We are really keen to hear about it. Floor is all yours.
Thank you so much, Matthias. It is really a privilege to be here today and for you all to listen a little bit my view, but then also the emergency physician's view and a view from Finland. I am Eva, emergency physician from Finland, the happiest country in the world, 6th year running already. Our healthcare is at least theoretically equal for everyone. Everyone gets equal healthcare, not depending on your financial status or even the level of your health insurance. At my ward, there can be a minister working for the government or a drug addict staying in the same room. Health and care workers can work without the ethical burden that the patients wouldn't be treated equally. However, this doesn't change the fact that in Finland, 88% of the nurses are considering changing their profession entirely, and 26% of the doctors choose not to work for governmental positions, such as in hospitals or healthcare centers on which our healthcare system relies on. I have a list of reasons. The list is so known to us that it could be lyrics to a song, to a hit song. And I think we know it by heart already at this point. These lyrics are not new. These lyrics have kept their status for decades, even before COVID. Now we just remember them a little bit better. It goes something like this: equal and sufficient pay for demanding job, decent working hours, circulation and good planning in shifts, education and training at work, proper leadership and organization of work, mobility of healthcare workers, leveraging digital technology, sufficient recruitments, awareness on multi-professional teamwork, equality in gender and ethnicity. And I think you know that the lyrics go on and on from here, and those were the basics. However, this song is lacking the final chorus. How do we defeat the problems and rise to do the job as well as we are trained to do? There is a huge stigma about mental health among the health and care workers. You will rather say that you are on a sick leave on a somatic reason instead of saying that you are scared that the one patient might hit you again, which happens at my workplace all the time. We have a strict safety measures in most of the workplaces in developed countries. These safety measures should include psychological safety, safety to say that you are scared to go to work, safety to say that you are mentally too drained to hold another dying person's hand. These safety measures are often overlooked. Right now, it is considered that it comes with the job. If you can't take it, move on. And we have. Think about what would happen and what has happened if we wouldn't offer any mental support for firefighters, military personnel, or police officers. The policy brief on global health workforce responses states on the page 22 that strategies to support the mental health on healthcare workforce at the individual level may attenuate some of the effects of workplace stressors, but fails to address their organizational and system level drivers. This is true, certainly, absolutely. Mental support doesn't take away the factors that strain you. Mental support doesn't take away bad planning, bad shift work, over hours, bad leadership. It doesn't take away harassment. It doesn't magically heal the patient. It doesn't make the violent patient magically stop being violent. It doesn't heal and take away the lyrics of our song, but it helps us up to a certain extent from getting ill from them, leaving our work and giving up. The Finnish National Occupational Center states that mental support is needed to help the health and care workers being able to work in demanding circumstances. It is also stated in the governmental program. Local interventions have been made by the Occupational Center of Finland, hospitals and organizations such as FinHem that has developed a low threshold teams-based counseling service for healthcare workers. The effects of the counseling service will be published. It is time to make the chorus line to that song we've been singing for years and take true action. We, the health and care workforce, are ready for that. Thank you.
Thank you so much, Eva. Quite fascinating. And if I follow your lyrics, actually, it's the basics, isn't it? And in a way, also sustainable development goals, because you were arguing decent work, gender equality, pay equality. These are actually the basis, you know, for addressing mental issues in countries. And you were also very clear about what can be the impact actually of specific mental health actions. So that was very, very good and very clarifying. And we are super curious hearing about the outcomes, but what I hear from you and seeing your smile, I'm quite sure that the evaluation will be very positive of all these measures. Thank you so much, Eva, and we come back to it later in the panel discussion. And now it's my immense pleasure to ask Aisha Holloway. Aisha, please join us and fill us in a little bit on Scotland and the UK. Aisha, the floor is all yours.
Thank you so much, and thank you for this wonderful opportunity. I'm delighted to be here and give you some insight from a nursing perspective. I am a registered general nurse, and my clinical background is acute medicine and intensive care, public health, and I'm now at Edinburgh University, where I have the chair in nursing studies. So I've been really interested to hear the discussions and the points made by Margaret and Eva, and I wanted just to share some insight into the observations that I've made, and I'm just going to share my screen with you. I have a couple of slides that I just want to show you to situate where I'm coming from with this. We've heard that during COVID, there were many interventions, responses, and Margaret nicely put it that these were very much at an individual level. And some of the questions that we've put to ourselves over the last months, and certainly at the 5th Global Forum, is what did we learn? What worked well, what is evidence-based, and what are we going to take forward? And I guess I want us to stop today and just think about this in a little bit more detail. And the reason I'm showing you this is because I feel we need to move from the individual to the bigger picture. And I love this model, the systems model of clinical burnout and professional well-being. What causes it? What are the outcomes of it? What are the consequences? But also, what can we do about it? And I'm going to specifically focus on those bigger issues, the organization, the environment. So these 3 levels of the systems model, I think, offer us an opportunity as a framework to understand what we might take forward, where it would sit, how it interlinks. The healthcare worker does not work in isolation. They do not live in isolation. Their professional practice does not take place in isolation. They are part of a clinical community. They are part of a care team, a physical environment, but they work within a governance structure, an organizational structure, and within that bigger sphere, they work within a regulatory sphere where there are standards, there are ways of working that influence them within a healthcare industry, private, public, and then we have societal values. So these things are very important, and I really wanted to focus on these today, or just use these as a point for you to focus on. So I'm going to talk very briefly about Scotland. We can pick it up later in the panel discussion, but just to kind of locate you to what is going on in Scotland. In the UK, you'll know there are strikes. In Scotland, we've had a resolution to the pay deal, and alongside that, there are a number of initiatives that have come out of that. The pay negotiations have reduced working week from 37.5 hours to 36. There's protected learning time within that deal. There's a review of Band 5s, which is our entry registered level nurse. There is also, very excitingly, the launch of a ministerial task force, and I'm lucky enough to sit on that task force on nursing and midwifery. And it's going to zone in on leadership, culture, well-being, how do we attract and retain. And alongside that, there is the implementation of the Health and Care Social Safe Staffing Act in Scotland. So you see, Scotland is a hotbed at the minute of lots of things being thrown up in the air, and we're not quite sure where they're going to land. So what I thought would be useful for the second part is really thinking about this model and together how these factors influence and contribute to burnout, but what's happening practically. And I was thinking about, Matthias said, can you tell me what's going on? Well, yes, we've got lots of wellbeing hubs, we've got lots of resources, digital resources, but there's one thing that sticks out practically that I think people listening might want to take away with them, and that's around something called clinical supervision and restorative clinical supervision, or resilience-based clinical supervision. And there is a strong evidence base for that. And certainly what I'm seeing is, despite all these other new initiatives, there is this idea, and actually the NMC talk about this idea of preceptorship or support, particularly for newly qualified nurses. And that area for us is a significant issue around attrition. You know, it's one of the biggest groups that are leaving 18 to 30% of newly qualified nurses will leave within the first year, rate rising to 37 to 57% in year 2. So this is a group that we really want to, this is an asset we want to keep a hold of. How can we do that? How can we support our newly qualified nurses, our existing nurses? We do have a return from retired nurses policy here in Scotland that's newly out there. But there is something that is really interesting about this, the components of clinical supervision. What is its purpose? And it does align to some of the evidence-based factors that we understand are related to burnout and professional well-being. So we understand that stress and burnout happen, overwhelm, values related, but the point that Eva made about a safe space, where do clinicians go when they're burned out, when they're working, when they're suffering from mental health, into the clinical area every day? Where do they go for a safe space to discuss the troubles, the real anxiety that they are suffering, their mental well-being? And this opportunity of this supervision, which is delivered by, charity organisations do it, the Foundation of Nursing Studies do it, our trusts and our health boards deliver this, but they're not delivering it in a mandated way. It's quite sporadic. It's not set out systematically. So it depends where you work, where you will find this. But what we understand is where this is happening, we are seeing great results. We are seeing reduced stress and burnout, positive impact on team working, which is one of the things we've identified. And then this ability to cope with various demands. My only caution with this is, are we just setting people up to just keep on managing and dealing with these things when actually that's not what they should be doing? And what we certainly hear is this alone won't fix it. There is no amount of clinical supervision where we're checking in, we're teaching people about how to understand their emotions, reflective practice. That is only going to go so far. What they want is good working conditions, fair pay, safe working, and they want somewhere where they will be able to care for their patients, provide safe care, and have a career that is fulfilling. Nurses do not come into nursing to undertake lots of admin, undertake lots of paperwork. They come into nursing because they want to give direct, patient-centred, safe care. And that is really at the heart of being a nurse. It's values-driven, it's who we are. And that's what people need to understand. But the two together, where we have these other elements of the working conditions, are such a key factor. They are such a driver for this. So we can implement clinical supervision and we can evaluate it. There's a professional quality of life outcome measure. It's all there. And staff are really responding well to this, but that alone is not going to work. So the task force and the discussions that are going on in Scotland at the moment really provide us with a fantastic opportunity to consider how we can take the best of everything, but sit it and align it within frameworks such as this. And alongside this, I think it will allow us to see the intersectionality of all these elements. And when we talk about the health of the workforce, I think we might have to rephrase that, because that's putting the onus on the workforce. But we have to understand there is organisation and there's a wider environment where there needs to be systems change. I think I'll leave it there. I definitely don't want to overrun my time. And
thank you so much. I think that was excellent. And for me, it resonates very well with what Eva was saying, because Eva was stressing in the first place, decent work, equal pay, gender equality. And actually, you're zooming even into it a bit more granular, because you're talking about the clinical supervision. And funnily enough, a colleague of mine who's doing research in hospitals told me that many of the staff don't trust their line managers actually anymore. They don't trust their care managers and so on, and they don't get involved into clinical supervision actually anymore. They feel left alone. And I think this is very much a kind of organizational thing, and rightly so. It's about the healthy organization and the healthy context, and not so much about the ill health of the nurses. That's fantastic. We come back to this. I'm sure this has raised a lot of attention in the chat box. And now it's my enormous pleasure to ask Jim Campbell to join us. Jim, we've asked you to join here as a discussant, you know, listening to the colleagues, hearing the reports from Margaret. First of all, the overview. I mean, you've been commissioning it and working with us on it and on the key messages quite intensively with your staff and your colleagues. And then you hear the testimonies from Eva and the input from Aisha. I think everything is very familiar to you, you know, but for us the question is, you know, how do we move on to make here really actionable stuff out of these very important COVID-19 learnings? Jim, please.
Thank you very much, Matthias. Good afternoon, good morning, good evening, wherever people are joining from. Firstly, a huge appreciation to Margaret, Polly Pittman, and all the co-authors for the evidence brief, and the team at the European Observatory who collaborated with us for this. I just want a few reflections, maybe 4 points. The title of this brief was very clear. Number one is to inform future workforce development. The global experience of COVID-19 around the world, how to look at that, extract lessons learned, and then inform our policy discourse and our policy action going further forward. And Margaret highlighted, you know, the 10 policy recommendations that we have, which are essential to come further forward. Secondly, both the interventions there from Eva and Aisha really talking to multiple elements of those policy recommendations. The need for the reality that COVID-19, the pandemic, has really exacerbated pre-existing conditions in the workplace. The need for decent work, the need for psychological safety, for occupational health and safety, for a workplace free from violence, harassment, or any gender issues, being part and parcel of that work. And that's the theme that we had in the Global Forum, convened under the sort of continuing discussion of protect, invest together. So that protection, Margaret said it in her closing statement for her intervention, that protecting and supporting the workforce is absolutely essential, really validated by the two elements there. The other, number three, the point that's coming out really to say that actually the world has been very good at documenting COVID-19 and documenting the issues, but also there are a lot of things to be recognized that are really potentially beneficial for the long-term sustainable journey that we need. Not everything that was conducted in the short term is appropriate to be continued in the long term. We saw the negatives and the positives in Margaret's overview, but there is an opportunity to carry that forward. The use, looking at the scope of practice, looking at team-based roles, looking at digital tools and technology, and making sure that is available, that we don't create a global digital divide coming forward. So that's really the opportunity that's coming out of it. Picking up within that opportunity, just really want to highlight what Professor Holloway was just saying from the Scotland, the UK, the nursing experience, and talking back again to this actions going forward, this need to look at our evidence base to say there is an agenda where government, whether it's this new task team in Scotland, this new task force that's been highlighted here, but government has a responsibility, as does all employers, to make sure our institutional engagement is actually driving forward those protections, those investments into the individuals that we are dependent upon for our health and care services in the future. So that's going to be that institutional ability. That's the together agenda that we've been talking about. This isn't exclusive to the health sector. It is about the right education, continuous lifelong learning, continuous career development. It's about the right jobs. It's about making sure that, as you said, Matthias, about some of the SDG targets about economic empowerment and gender and equality at the heart of our deliberations to come further forward. So we have, from the Fifth Global Forum, a set of conclusions and a consensus coming out of our deliberations. This first policy brief really set that scene, and a key thing is that we're moving forward, working together with the political leadership to drive those actions for the future is really what we want to see. Back to you.
Thank you so much, Jim. And I think rightly so, you emphasized government responsibility. We are very clear there's a lot of responsibility. And that's in a way a red thread throughout the three policy briefs, because each of them, each team individually identified that the political leadership is very much key actually to move things forward. And it's not just, well, of course, the political leadership at the center and across departments, but it goes well beyond education, finance, and employment. It reaches into civil society. Think about all the professional associations. I mean, we've Eva with us, who's also civil society in a way with her organization, and we need to count on all of them. And for all of you who are interested in this is a topic which we will discuss next week, actually in much more detail. So the together element of the Global Forum is not just a nice element, but it's an absolutely indispensable part of bringing the health workforce issues forward. So that's great. Erika, I know you had an eye on the chat box, and I guess there's quite some stuff coming through. I hope not only have we copied documents, but also a couple of comments, questions, ideas. Please fill us in what's been exchanged.
Some very interesting things coming through in the chat box, and some really interesting sort of more political questions coming through as well. Quite a lot on the on digital solutions that developed during and were pushed forward and expanded due to the COVID-19 pandemic. What do we need to do to ensure these solutions are equitable, because not everybody's online, but also does it reflect a political willingness to invest in technological solutions rather than health and care workers? So is it part of a wider sort of like political trend? And it looks like health workforce innovations from the COVID-19 pandemic are not actually being sustained. That seems to be one of the messages that's coming across. Is this a problem? Is this a good thing? Is it a bad thing? Is it to be expected? So a little bit more on that might be interesting. And also, what do we know about the impact of workplace stress and burnout on quality of care? So is good mental health among our healthcare workers a prerequisite for good quality sort of care, particularly I assume with the that's for the nursing side of things. And then one thing on surging supply over the longer term. We need to surge, you know, we surged supply of health workers back in 2020, but of course we're facing shortages now. What are the long-term solutions for that? And in the short term, given that short staffing is extremely stressful, what can we do about it? What can we do about short staffing now? Okay, some really
that's great, Erika. Thank you so much. Maybe we start again with Margaret. Margaret, just pick out the question you feel best suited to respond to. I think you can say something to each of the questions, but please, we probably have a second round.
Goodness. Okay. Why don't I touch on increasing the supply of health workers in the long term? Okay, because we know that investments in education and training infrastructure will be critical in order to make that happen. We know that that has been a deficiency across countries that has been a barrier to increasing supplies of health workers across disciplines. But I want to speak maybe particularly to building up a certain subset of health professions and health profession students, and those would be ones that are best primed to serve our most vulnerable communities, our rural communities. There is very, very good evidence that recruitment of students from underprivileged communities and from rural communities ends up translating to their practice in those communities after they have graduated from their training program. And so what needs to happen is targeted investments and measures to ensure that those students are recruited early on, way before they enter the health professions education and training pipeline, that pathway programs exist, that sufficient investments in primary school exist to support those students, that mentorship opportunities, especially for students who might not see ample examples of the health professions within their communities, are available to serve as an example and provide the needed support and guidance to usher them through the health professions education and training pipeline. So it really is a long-term goal, and it needs to be treated as such. And the measures to build up the health workforce, the returns are not going to be seen overnight. They need to be implemented early on in the educational process, sustained and maintained in order to eventually see those return on investments and the enhanced workforce capacity that we need.
Targeted investment, and preferably not necessarily actually into the biomedical part, but rather in the social, anthropological, societal aspect of it, if I understand correctly, Margaret.
Absolutely, Matthias.
Eva, please.
I would like to address what was asked about the level of care when the health and care personnel is strained, and there's a couple of articles now in the chat which are very interesting. And then also my personal view is that working in the emergency department, we are always in a hurry, and in a statistical analysis and research made by the Patient Security Center of Finland, the most mistakes, patient mistakes, happen in a hurry in emergency settings. So when we are lacking personnel, we are in a hurry. And of course, this increases the risk for making mistakes. And this, of course, increases like the second victim phenomenon, where we become more stressed and more unable to work because we have a tendency to make mistakes under the stress. So definitely there is mental component into that, which you can find from this wonderful article that was linked here in the chat. But then also just the organizational factor, that when there isn't enough personnel, when the work is not structurized properly, you have to work outside of your comfort zone with too many patients, with too little time, and you make mistakes, and this brings a vicious cycle.
So there's a very clear link between working conditions, workplace stress, quality and outcomes, actually. And I think it has been proven in many ways. And you're just making the point, if we have shortages, if we don't have enough people, you know, we are accident prone, so to say. We will deliver not the quality we want to deliver. Excellent. Aisha, please.
Thank you. Thank you. I just popped one of the papers in the chat review, which was looking at the association. And I think the clear message is that there is a perception that burnout well-being is an individual's issue. And that's the factor, that's the kind of variable that we're interested in either manipulating or measuring. But actually, this is an organizational, cultural, societal issue that we must address. And it involves a really important outcome, and that is patient safety and outcome. And I think the one thing we haven't really touched on is around leadership and organizational leadership of individuals, whether that's nursing senior leadership, executive teams of hospital boards and organizations, and how we are really, I guess, trying to leverage that and help them understand how important that is for the people on the ground, the grassroots workers who are delivering that care in extremely challenging circumstances. To say this is a global crisis is an understatement. And I think, you know, there are many levels to this, which is why it's wonderful for us all to be here.
May I add one quick point to Aisha's point, following up on her? You talk about ensuring that leadership understands the severity of this and the solutions that need to be put into place. And one way that that can happen and that there's good evidence for is involve the workers, bring them to the table. Shared decision-making is crucial. Shared governance models are crucial. Talk to the workers because they're the ones on the ground and they should be part of that leadership body.
I just think about 1 or 2 countries I know very well, which have, at least in the hospital, very hierarchical settings, you know, and then you have hierarchies, but you don't have leaderships and the people are left alone and not taking part in the decision making.
And can I just point out, what I do want to do is just do a little pitch out for Scotland, because we are seeing playing out, without getting too political, within the UK, 2 ways of managing health workers' dissatisfaction with the current situation. And in Scotland, we have managed to come to some form of agreement and resolution by a government listening and coming together with these different stakeholders, the unions, the governments. It's been multi-sectoral and listening to what it is workers have to say. And
so proper leadership is not just a lonely decision from one at the top, but it's rather a whole of society endeavor, isn't it, Aisha?
Absolutely, absolutely. Thank you. And respectfully listening.
Very good. Jim, please.
So yeah, good. Thanks everyone. Just a couple of questions. Catherine Fries, that we've popped in the issue about compassionate and respectful care. Absolutely a key concern, that this issue about the burden of pressure and stress, does that result in poor patient outcomes, poor patient interactions? We've got some good evidence based on that prior to the pandemic, and we're watching with interest as the publications come out during the pandemic. And some of those are systems issues, others are individual areas that we need to improve upon. Natasha North asked a question about her experience, especially in Africa, the nurse migration, nurse attrition, nurse retention. Similarly, we had a major debate on this in the 5th Global Forum. All of these burnout pressures, these factors, these push and pull factors did also result in higher levels of mobility and turnover amongst the workers. The global north, economic demand creating opportunities, vacancies, jobs to respond in the surge led to greater opportunities for migration from all over the world. So that's having an impact. We're seeing the numbers. The new publication that WHO put out in March, the WHO Health Workforce Support and Safeguard List, notes with concern that the impact of COVID-19 may have created this demand, global economic demand for health workers, which is going to negatively impact some of the low and middle income countries. But it's happening everywhere. Just quickly on that point though, Natasha, some of the numbers that we're seeing around high turnover and nurses leaving the occupations is not necessarily being then translated into official government statistics in high income countries. There are as many people joining the health and care sector. So it's mobility within. The percentage that are actually leaving the profession and leaving the health and care economy is not being disaggregated and reported on accurately. So we need to really look at that from I know you're a university specialist researcher there. We need to look into that detail and disaggregate some of those numbers before we come out with generalized statement about nurse attrition. Thank you.
Tim, thank you so much. And thank you so much to all the speakers. That's been amazing. And I learned quite a lot, even though I've worked on this topic for quite a while. But thank you so much. And Margaret, maybe you as a keynote speaker, you can come up with 1 or 2 sentences helping me to wrap up the session.
I will try, Matthias. One thing that struck me when doing the research from this policy brief was that there are more similarities than differences in the workforce challenges that we face across the globe. Different flavor, but a lot of similarities. Therefore, I think that it's also an opportunity for shared learning, both within and across countries, and the potential for success in one region to benefit another. So perhaps we can turn this shared crisis and collective workforce trauma into a shared success by continuing to evaluate, share evidence and best practices, and have these types of discussions to sustain that momentum that we talked about and that is needed for transformative change.
Margaret, thank you so much. Learning from each other, and in particular, learning from different regions, that should be really a good priority. Thank you so much. And Annalisa, can you show the last slide? So for all of you who are interested in joining next week, we have as a topic working with, there it is. We have as a topic working with education, employment and finance, and the week after we discuss where all the money comes from for the smart investment we've already been touching upon today. So thank you so much and goodbye.